Let's move on to Dr. Yaranov, who's going to finish the morning's panel of talks, and then we can have a session with questions and answers. Thanks. Dr. Yaranov.
Thank you. Good morning. Well, it's not morning anymore. Maybe in Memphis it still is, but I'm still trying to get used to the time. But thanks for coming and thanks for having me. Great panel, great talks. So I am a transplant cardiologist. So how do you advance it? How do you guys advance it? Is it the mouth or?
Down arrow.
The click? There you go. Okay. So I'm a transplant cardiologist out of Memphis, Tennessee. We are a 22 hospital system across the Mid-South region of the United States. That's where Elvis Presley's from. That's what we're known for. And then we have two LVAD programs in the system. We have one transplant program, and we launched our Barostim program back in 2022. And so far we've done over 50 implants. I don't have an impressive follow-up that Advent Health yet has. But I'll show you a few cases that we've done locally and how we implement the therapy with a continuum of heart failure in our region. So before I start, I'll tell you that I came 5 years ago to the region, and I trained at the Cleveland Clinic back in time, and I thought my main contribution to Mid-South would be the amount of heart transplants and LVADs that I will perform locally. Little did I know, but back to the slide that Richa showed to us, majority of my patients are not or will never be a transplant candidate nor an LVAD candidate, but they all do have heart failure, and I had to figure out rapidly what to do with them. So I'll show you a few slides and expand on appropriate phenotypes for Barostim, appropriate timing. I'll reintroduce the concept of lifetime management of heart failure, which a lot of our structural colleagues, especially for aortic valve, adopted and run with really well. I don't think we do as well in the heart failure space with that concept. We'll talk about local GDMT titration protocols and titration protocols for Barostim that we use and how we monitor the response. We've seen this, certainly this is a label for United States. We've heard about it already. It's in YHA class 3 or in YHA class 2 patients that previously had class 3 symptoms despite guideline-directed medical therapy, ejection fraction less than 35%, and lucky you guys in Europe, unlucky us, NT-proBNP less than 1,600 to get into BHF or to get Barostim in the United States. So how do I break it into for our clinicians, and how do we think about those patients where they are in our clinics? Those are the patients who already have their ICD, ischemics, non-ischemics, who do still persist with exercise-limited symptoms despite guideline-directed medical therapy. Those are your CRT non-responders who initially qualified for class 1 or class 2A indication for CRT, but remain exercise-limited despite the optimization and who fail to reverse or model after implantation of CRT. Patients who continue to have adverse events and continue to be hospitalized with recurrent CHF admissions despite maximally tolerated guideline-directed medical therapy. And those patients who are intolerant to conventional therapies or conventional GDMT. And I do want to underscore, intolerant not because they're end stage, intolerant not because they have autonomic dysfunction, because those patients are not going to do well after implantation, but those are patients that have other type of toxicities, whether it's financial or side effect type of profile toxicity. So we've seen this graph today, we've seen this multiple times. All we try to do in our clinics and our practices is to make this curve not as steep and have less downturns to really extend the timeline for those patients and make sure that we're able to take care of their heart failure through all the life of the patient. Device therapies, primarily Barostim, for the point of conversation today, is one of those interventions that when done early, and I'm sure you've seen it on the previous slide, can really change the trajectory of this graph. I'll show you some novel data that was presented at THT this year, a couple of months ago. And this is analysis from BHF trial that Dr. Patel presented earlier. Looking at the advanced heart failure therapies in patients with that were randomized in a BHF. And you can see that there were In the control group, there is 27 end organ interventions, not just heart transplant LVAD, but also other devices, cardiomems, and use of CRT for non-class 1 indication. And those in control group had significantly higher amount of the events, namely VAD implants, and use of other therapies like CCM, CRT, cardiomems. What this would in a way suggest that those patients who undergo Baroreflex activation therapy did have fewer events that would trigger devices like cardiomems, that would trigger other devices or end organ intervention that I mentioned to you before. And ultimately, that's me trying to get a better graph, but still failing at it. But hopefully we'll get a better one sometime soon. But this is what I see as a concept of lifetime care of patients with heart failure. So let me show you a couple cases. Again, I have this 23-year-old female who has peripartum cardiomyopathy. She's African American. She has a titin mutation. She gets diagnosed around time of delivery. I'm not sure that's really related to her delivery rather than her genetics. She does have NYHA class 3B symptoms, stage C. By the ACC and AHA staging, she does have ICD already, and she has QRS. There's 120 milliseconds, and she does have IVCD, which does not qualify her to receive a CRT device. So in 2021, she was diagnosed. That was at age of 20 after delivery of a healthy child. She presented for evaluation of exertional dyspnea despite guideline-directed medical therapy. Her GDMT, you can see, has moderate dose of carvedilol, low dose of Entresto, spironolactone 25, Farxiga or dapagliflozin 10 milligrams. She did have several events, more so recent admission for heart failure, and she even got the newer kid on the block, Vericiguat, at 5 milligrams daily right now, and we're not able to up-titrate her guideline-directed medical therapy any further due to symptomatic hypotension. So she presents to our Advanced Heart Failure Center to be evaluated for end organ intervention, namely transplant or LVAD. Her echo shows ejection fraction of 20%. Her IDD is 7.7 centimeters. She's dilated. She doesn't have any valvular abnormalities, and she does have moderate RV dysfunction. She does get a CPX at that point. Her peak VO2 is only 10.2 and only 36% predicted for her age and gender. VVCO2 slope is 24.7, and she exercised well. Her RER is 1.19. So her right heart cath has somewhat normal filling pressures. Her wedge is only 11. Her cardiac index is 3.42 by Thermos and 2.4 by FIC. And she's pretty dilated. Her SVR is 1050. I don't see any way to get this vasodilators any higher. Then the discussion happens with her, and one thing she doesn't want to have at 23 is a heart transplant or an LVAD. And she reads about a device called Barostim and convinces everyone to put one in. She gets a Barostim implant in July 2023. She meets the label indication. This is a follow-up from October 2023, and I can give you a 2024 update. It's pretty much the same. But she was rapidly titrated with the goal at 8 milliamps right now. We were able to up-titrate her guideline-directed medical therapy. Her core reg went up to 25, and Entresto now is 100 milligram twice a day. This is her repeat echo, not as impressive as in the previous case. There is no recovery improvement, rather maybe some marginal dilatation of the ventricle, although her symptoms markedly improve. And she did get another CPX in January 2024. You can see that instead of 6 minutes of exercise, now she exercised for 9.5 minutes. Her peak VO2 went up to 14.3. Her VVCO2 slope is 27.3. If you look at the percent predicted, it's still on the lower side, and she did have good RER. So again, just reminding you about this window of opportunity to change the trajectory for the rest of her life, so that she still did not get a heart transplant or did not need an LVAD, and doing real well taking care of her child. I have another case to show you, and this is I call it a typical Memphian. It's a 67-year-old African-American male with a non-ischemic CKD stage 4, diabetes, BKA because of diabetes, obesity, not a candidate for surgical therapy for a multitude of reasons. So his echo is again 20-25%. His IDD is 8 centimeters, has mild AI, moderate MR, moderate TR, moderate RV dysfunction. Nearing stage D, NYHA class 3B, multiple admissions with heart failure. And we cannot get him on guideline-directed medical therapy short of spironolactone and Farxiga. And you can see because of his CKD, he even uses his spironolactone with potassium binders to get at least some medical therapy. He was not able to finish the 6-minute walk test because how he felt that day. But he also met the indication for Barostim. He was implanted in February 2023. He was up-titrated to 10 milliamps at month number 3. And you can see that good drugs popped up on that list. You can see all of us talking about it, but certainly that is something routinely seen after the up-titration. He was able to get on low-dose Entresto. He was able to get on a small dose of Toprol. And now he was able to finish a 6-minute walk test. Obviously, he went only for 160 meters, but certainly symptoms improved, and he did not have any hospitalization in the 6-month follow-up. Okay. So Dr. Patel briefly mentioned to you his own protocol. I'll show you how we in our center think about utility of Baroreflex activation therapy. One thing I want to caution you, we have 3 implanting facilities in our 22 hospital system, and not all of them have access to CPX. CPX is not a mandatory tool for us to put it, to put Barostim into a practice. But that's, we're transplant cardiologists. That's what we do. That's why I have the slide for you. But I have here a peak VO2 cutoff, 12. If you're below 12, obviously you need to be evaluated for transplant candidacy. If your rest and hemodynamics are abnormal, we would go ahead and proceed with an organ intervention. But if your rest and hemodynamics are normal or borderline, we will give a chance to Barostim if you feel the rest of the criteria. And obviously, if you're not a candidate for advanced therapies, we will proceed as well. Peak VO2 more than 12, that's an easy one. You follow the label, American label or European label, and NYHA class 3-2, non-CRT or CRT non-responder. EF less than 35%, and that's the typical patient we would implant. So I've changed that slide a little bit to reflect on what we do with regards to titration. We used to start and do titration per BHF protocol, which took us quite a few months. Nowadays, we are doing a lot faster titrations, and usually most of our patients would be at the max output by week number 8. Depends on the patient's starting criteria. We would attempt multiple different things in this titration pathway. So if your patient is already on guideline-directed medical therapy, or regardless, any patient that starts titration, you would notice that Baroreflex activation therapy promotes natriuresis. So majority of the time, every titration would assess their volume status to make sure that they are not over-diuresed and adjust their diuretics with every visit. Now, if your patients were not, and that's the second line here, on guideline-directed medical therapy due to hypotension, this would be the patient that at every titration would be thinking about reintroducing one of the GDMT portions to get that mortality benefit of the GDMT or quadruple therapy. And then I'll urge you to remember that there are other multiple reasons for intolerance that I brought up in the beginning, whether it's access, which is very pertinent for us, especially in my region, whether it's financial toxicity, whether it's any side effects, why your patient is not on GDMT, and we ask our providers with every visit to address why guideline-directed medical therapy is not introduced yet if it's not hypotension. We do use 6-minute walk test routinely, and we use cardiopulmonary exercise testing on those patients who can be candidates for advanced heart failure therapy, fit the age and the rest of the criteria. All right, I have 40 seconds to Oh, sorry. All right. So window of opportunity in lifetime care of heart failure patients. The window is becoming wider. We have new drugs. We have new therapies. We certainly now in 2024 can change the trajectory of that graph that all of us showed you. A lifelong care of heart failure is important, whether we count in years added or therapies delayed. Quality of life matters, maybe not for cardiology fellows because that's how they teach us. It's all about mortality, but for some reason for my patients, quality of life matters a lot of times even more than mortality. Individualize, initiate, and titrate, and that's the motto we have in our clinics to make sure all of those patients get all the therapies that are needed. A lot of times I ask what happened to our VAD numbers or transplant numbers after we started using Barostim. Barostim is not something that will kill or slow down your VAD or transplant program. It's a great tool that will help enhance your program, but we have not seen any differences in numbers post Barostim utilization. And a couple pitfalls, too late in the disease progression is too late. Autonomic dysfunction is hidden there. Be careful. You're not going to do well if you bat someone with autonomic dysfunction. And GDMT titration is important, regardless how you started and where you started. And again, overlooking patient symptoms and symptom burden on quality of life is a big pitfall that a lot of us tend to fall into. Well, thank you. That's what I have. And